Good afternoon. My name is David Sandberg. We're going to begin this webinar on treating brain tumors in children, focusing on minimally invasive and novel surgical approaches. I'd like to welcome all of the viewers who are participating in this. I'd particularly like to take a moment to thank the viewers who are the families and the parents of children with brain tumors. Having done this for a number of years, I'm always inspired by you and what you go through. I'm the father of 2 young children, and I know how much love it takes to raise a child. And I know how devastated you must have been when you have received that first diagnosis. The good news is that our treatments are improving, and there's a lot of hope for children, even with malignant brain tumors. But I certainly salute you, as your courage in facing these diseases inspires me on a daily basis to try to do my very best. To tell you a little bit about myself, I'm the Director of Pediatric Neurosurgery and an Associate Professor at the University of Texas, Houston, and Children's Memorial Hermann Hospital. We have a combined pediatric brain tumor program with MD Anderson Cancer Center. So our children who need adjuvant therapies such as chemotherapy and radiation therapy receive those therapies with a combined program at MD Anderson, and we have combined tumor boards and conferences so that every patient has a comprehensive approach to their disease. So beginning with the webinar, just by way of background, I'm really going to focus here on treatments, but by way of background, pediatric brain tumors are the second most common cancer in children, the most common solid cancer, and the leading cause of cancer death in children. The good news is that while many malignant brain tumors in adults have a much worse prognosis, even the most malignant tumors in children have a much higher survival rate with modern therapies. There are between 2.2 and 4 cases per 100,000 children per year, and the number that's thrown around most commonly is actually 2,000 new pediatric brain tumors diagnosed per year in the United States. But this is a more modern source. There are actually probably more towards 4,000 new pediatric brain tumors. I think they're being diagnosed more frequently based upon more frequent and better imaging studies being obtained. And also I believe that the incidence is rising for reasons that we don't fully understand. The etiology, the cause of the vast majority of these tumors, is not known. So there are a number of ways that a child with a brain tumor will present to me as a pediatric neurosurgeon, but the most common is the presentation with signs and symptoms of elevated intracranial pressure. So, for example, in the imaging study that you see here on the right, there's a child who has a large tumor filling the 4th ventricle of the brain, which has caused obstructive hydrocephalus, which means that the ventricles, the fluid spaces of the brain, these black spaces that you see here, are considerably enlarged. Because of the increase in the fluid spaces, a child will present with headaches, which are often worse in the morning. Of course, any child can develop headaches, but these are headaches that tend to be persistent. They tend to be associated with vomiting. In very young children, interestingly, you can have vomiting without the symptoms of headache, and sometimes young children, of course, aren't as verbal and able to describe their symptoms. Lethargy, a child is just sleeping much more than normal. Papilledema is swelling of the optic nerves that an ophthalmologist or other physician can see when doing a direct exam into the back of the eye, and that can be a sign of increased pressure in the brain. In young children, we often just see an increasing head circumference. The size of their head gets larger and crosses percentile lines, which means, all of you are familiar with the head circumference curve at the pediatric office, in your pediatrician's office, where they measure the head and they tell you it's the 50th percentile or the 70th percentile or the 30th percentile. If a child's head is crossing those percentile lines, they were previously in the 25th percentile, and then they're the 50th percentile, and then they're the 80th percentile. Each time you go back to the doctor, it's crossing that line. We get worried that there may be a process in the brain that is causing increased pressure. And also you can feel the fontanelle, which is the soft spot in the top of the head. The anterior fontanelle is the soft spot that you feel, and if it's fuller than normal, that could potentially be a worrisome sign. So in addition to signs and symptoms of elevated intracranial pressure, tumors present to me as a pediatric neurosurgeon in a variety of ways, and it all depends upon the location of the tumor. So these are 4 examples of MRI scans of children who presented to me with brain tumors. This is another child who has a tumor in the posterior fossa, which is in the back of the brain. This tumor is filling the 4th ventricle of the brain and causing a degree of hydrocephalus, which is when the fluid spaces are enlarged, as I described before. And this patient presented with headache and vomiting, but could also present with difficulty in terms of their coordination or an unsteady walking or gait, because it might be affecting the cerebellum, which controls those functions. This is a large tumor which presented, and this is in the supratentorial compartment, which means it's in the cerebral hemispheres as opposed to the back of the brain, the posterior fossa, which we described before in this patient. And this patient would more likely present with a seizure or with weakness, because both the tumor and the area of swelling, you can see this black signal, hypointense signal we call it, is causing swelling of the brain, and this includes the areas which control motor function. So this child might present with a seizure or might have weakness on the other side of the body from this tumor. So if the tumor was on the left side, the child might have right-sided weakness. This next tumor, you can see this massive tumor, which is in what we call the suprasellar region. The sella, or sella turcica, is the area of the brain where the pituitary gland sits, and this area above is the suprasellar region, and this is massively enlarged. It's mostly a cystic tumor, and this would likely present with either visual changes because it's pressing on the optic chiasm, which controls the visual fibers which emerge from each optic nerve, or with endocrine disorders because it's compressing the hypothalamus, which controls secretion of a number of hormones, which could lead to a variety of both laboratory abnormalities and clinical abnormalities that would be detected. This final case is a tumor located in the pineal region. The pineal region is right smack in the center of the brain, and this tumor again has caused what we call obstructive hydrocephalus. It has blocked the fluid pathways, so the ventricles, the fluid spaces of the brain, are enlarged. And in addition to headaches and vomiting, this patient, because of where this tumor is located, would likely present with what we call a paranodes syndrome. And a paranoid syndrome includes a difficulty in looking up, and it might also include what we call nystagmus, which is when the eyes can be jerking back and forth. When a patient comes to a pediatric neurosurgeon, there's a lot more that goes into our decision making besides just where's the tumor and is it safe to remove. There are a lot of things that we need to assess. So we need to look at CSF, which is the cerebrospinal fluid. Has this tumor disseminated or spread beyond the location of the original tumor site? Now, unlike other tumors in other areas of the body, such as a breast cancer, which may spread to the lungs or the liver or the bone, tumors in the brain very rarely spread outside the central nervous system. So they may spread to other areas within the brain, or they may spread to what we call the subarachnoid spaces, which are the spaces around the spinal cord, but they rarely spread elsewhere. So typically, to make sure a tumor has not spread at the outset, we'll obtain an imaging study not only of the brain, but an MRI scan of the total spine to make sure that tumor hasn't spread. We talk about the anatomic location in determining whether a tumor is safe to resect. Most tumors in children, we would like to obtain a gross total resection, if possible, rather than just a biopsy, because with a gross total resection, for the overwhelming majority of tumors that occur in children, the survival is better if you can remove the whole thing surgically, even if they need additional therapies. Hydrocephalus is when there's a problem with fluid circulation in the brain, as I mentioned, and we need to make sure that we're treating the hydrocephalus because that in and of itself can be a life-threatening condition. And I'll give you a number of examples of treating the hydrocephalus simultaneously, particularly with endoscopic, minimally invasive techniques. So in terms of anatomy and surgical resection in general, we can say that pediatric brain tumors that are in regions safe for surgical approaches should be resected as completely as possible. And there's good data for that, both for benign and malignant brain tumors. So this is one study back in 1999, but still relevant. And these were children with malignant brain tumors. This is called the Baby POG-1 study. And in children under 3 with malignant brain tumors, the single most important survival predictor was degree of surgical resection, with a doubling of survival if you can obtain a gross total resection versus a subtotal resection. And this holds true in study after study for both benign and malignant tumors. So here are a few examples. This is a patient who is a 1-year-old boy who presented with significant vomiting, which eventually led to an imaging study of the brain. And what you can see is this massive, massive tumor in the posterior fossa in the back of the brain, filling much of the cerebellar hemispheres and the fourth ventricle and pushing aside the cerebellum. So you see this thin rim of cerebellum on one side where there's a larger amount of cerebellum on the other side. So we performed a gross total resection. You can see on the imaging study below, this is after surgery. This is a sagittal T1 weighted MRI scan before surgery and after surgery. And this is before surgery and after surgery, showing a gross total resection. The pathology in this case was medulloblastoma, which is a malignant tumor, but one that is very responsive to both radiation and chemotherapy. In a 1-year-old boy, we wouldn't give radiation therapy. We would just give chemotherapy at high dose. And this child would be in for a long road, but would have a very good chance of a long-term survival. Here's another example. This is a 3-year-old girl who once again presented with nausea and vomiting. And what you can see, all of this signal abnormality, which extends from the frontal lobe into the ventricle, is abnormal, and you don't see it on the other side, and that's a brain tumor. And we removed it, and the pathology is an ependymoma, which is a tumor that in this location of the brain does not need any additional treatments. So the only thing that we would need to do with this child is follow this child with subsequent MRI scans over time to make sure that the tumor does not recur. Here's an example of a 4-year-old boy who presented with visual changes. Basically, his parents found that he was bumping into walls, so they took the patient to the ophthalmologist. The ophthalmologist, astutely in a 4-year-old boy, noticed that there was a deficit in his visual fields, meaning he couldn't see very well in the periphery while he could see very well centrally. And that's tough to diagnose in a young child. So he said this child needs an MRI scan of the brain. And the MRI scan showed this large cystic lesion in the suprasellar area, which was compressing the optic chiasm, which is where the 2 optic nerves join. So here's the lesion that you can see. And then here's an intraoperative view. This is under a high field operating microscope after doing a craniotomy, removing a piece of bone and opening the skin and opening the dura and separating. The dura is the covering of the brain, and separating the frontal lobe from the temporal lobe. And what we see is here's the internal carotid artery, which separates into the anterior cerebral artery and the middle cerebral artery. Here's the optic nerve, and then right next to the optic nerve is the optic chiasm. And if you work back this way towards the middle, you would see the other optic nerve on the other side, and you'd see the optic chiasm, which is compressed by the tumor, which we would protect. We would decompress this cyst and then remove this tumor completely if it was safe to do so. Here's another example of a gross total tumor resection with a craniotomy. Now, these are the more traditional approaches for treating brain tumors, and later in the talk, I'll show you some of the more minimally invasive approaches for treating brain tumors. This is my favorite type of tumor to treat because this particular tumor I know that I can completely cure with a tumor resection. This is a 12-year-old boy who presented with headache and vomiting and has this cystic lesion with a solid component that occurs in the back of the brain in the cerebellum. And here's after surgery. The pathology is the most benign form of a brain tumor, which is a pilocytic astrocytoma. And in this location, with a gross total resection, I can look the family in the eye and tell them that this child is cured. Of course, we will need to follow them with serial imaging studies because very, very rarely these will recur, but it is very uncommon. A final case showing a gross total tumor resection of a deep tumor within the brain. And I show this partially to show you the contrast with some of the endoscopic procedure. So you can see how invasive a brain tumor surgery is when it's done in the traditional way, and how much less invasive it is when we can safely achieve an endoscopic tumor approach or resection. So this is the example of a 14-year-old boy who presented with blurry vision and was found to have a paranode syndrome. So this child has a tumor that is located near the pineal gland, and you can see it on this T1 weighted sagittal image. And to orient you, the front of the head is this way. Here's the nose, here's the back of the head. This is called a coronal slice, and you can see this large lesion in the center of the brain. And this is a diffusion weighted image, and this tumor is bright on diffusion, which makes us think that it's very likely to be what's called an epidermoid or dermoid tumor. These are benign tumors that can be cured with surgical resection, but can be life-threatening if they're not removed completely. So here's what we do. So this child is asleep and under general anesthesia. We shave a small amount of hair. I try to shave as little hair as possible in my patients these days, particularly in the young girls, because we want them to go back to school and look like they didn't have any surgery at all. We then make a large incision, and this is the skin that's reflected. We make several holes. Excuse me, let me move my arrow here. Here's the skin that's reflected. We make several holes. These are called burr holes in the skull. We then use a high-speed drill to remove a large piece of bone. And what you're looking at here is the dura mater, or the dura, which is the covering of the brain. Now you can see here that we've opened up the dura and we're looking at the surface of the brain itself. Now we've opened up the dura, we've reflected, this is called the falx cerebri, which separates one cerebral hemisphere from the other. We try not to retract the normal brain to try to avoid injury with retraction, but we will retract this dural membrane, the falx, and deep, you can see deep within the cavity, we've cut what's called the tentorium, which sits between the cerebral hemispheres of the brain and the cerebellum below. And once we cut the tentorium, under that tentorium, you can see this yellowish, pearly material. That's the tumor. All this is under a high-field operating microscope. And then here's at the conclusion of the tumor resection, and you can see that there's none of this whitish tissue left. So this child had a gross total surgical resection, will require no additional treatments. So there are many things that we consider intraoperatively when we're performing a craniotomy for a brain tumor. There are many considerations as far as anesthesia is concerned. We worry about temperature control. We worry about fluid management in these children. We worry about skull fixation in adults. And this is one of the reasons you want a pediatric neurosurgeon to take care of your child who has a brain tumor, because we think about these issues. I've seen cases where skull fractures are caused by adult neurosurgeons who just aren't familiar with treating children and how thin the skull can be. And we know when to put in skull pins for fixation and when it's not safe to do so. We use frameless stereotaxy, which is really neat, and I'll show you some examples of that. It's using direct MRI guidance during the surgery to show us exactly where we are. In truth, it makes some of our surgeries quite idiot-proof. We use functional mapping and awake craniotomies. There are some children in which a tumor is located very close, for example, to the areas which control language function or motor function. And I want to know for sure when your child wakes up after brain surgery that they're going to wake up without a neurological deficit. So in a very special child, particularly a teenager or older, we'll be able to do actually the surgery while they're awake, so we can monitor those functions. We can have them speaking while we're actually resecting a tumor to make sure we're not hurting their language function. And of course, we worry about blood loss in children. Small children have a very small circulating blood volume. Some of these tumors can be quite vascular or bloody, and so we need to be very careful to adequately transfuse blood when needed and to be on top of how much blood we're actually losing. So on the left here is an example On the left here is an example of an adult who's in what we call Mayfield pin fixation. The patient is positioned on his side, and he has pins which are holding the skull in place so he doesn't move during surgery. In this 1-year-old child on the right who has a brain tumor, it would not be safe to put this child in pins. And so we basically just use a padded horseshoe. There are disadvantages to this, but we know how to overcome these disadvantages in surgery. This is really neat. So this is frameless stereotaxy. For any of you whose children have undergone surgery with frameless stereotaxy, you'll know what I'm talking about. The child gets an MRI scan right before the surgery, and then in surgery, we can basically have a pointer using infrared technology and point to a specific area on the skin or on the skull or on the brain, and this MRI scan comes up in multiple planes, and we know exactly where we are. It eliminates any doubt in terms of the trajectory of moving towards a tumor and knowing exactly where you are. So here's going a little deeper into the brain and then going a little deeper, and this is exactly the type of view that we would have at surgery. And here's an example of us using frameless stereotaxy at surgery. So the brain is exposed here, and we have a pointer which we're pointing onto the surface of the brain. And here's the television monitor, where at the same time we're looking and we're saying, oh, okay, I know for sure that that spot that I'm pointing at is exactly here, which is a little bit in front of the tumor or behind the tumor or next to the tumor, etc. So we can be very safe in approaching the tumor by knowing exactly where we are. So functional mapping I mentioned, this is a grid which can go on the surface of the brain, and you can apply a stimulus, an electrical stimulus, and based upon the responses that you get on the surface of the brain, this is the grid that I'm talking about, you can see exactly where the motor strip is, which turned out to be right here. So I know that if I enter this gyrus or this fold of the brain, I'm going to cause a deficit in movement on the contralateral, on the opposite side of the body. So if there's a tumor that's deep, I'm going to choose not to approach it via this gyrus, and maybe I'll go in the one behind or in front of it, depending on the anatomic considerations. So now we're up to one of my real favorite topics, something that I've spoken about a lot at national and international meetings and written about a lot because it's a real passion of mine. Anytime we can do a more minimally invasive surgery, we do it because we can, instead of having that big craniotomy, a large incision, a big scar, as we talked about before, we can have a very small incision on the top of the head, which can be totally covered by hair, a much more painless operation, and have children out of the hospital much quicker. So what you're looking at is an endoscope. An endoscope is essentially a camera with a light source which attaches, and basically we can insert this very small tube into the brain, usually into the fluid spaces, but sometimes into other spaces, and get an image which comes up on a screen. You can see us performing endoscopy here, and we can navigate within that space and then perform whatever procedure we need to do. So let me just give you an example. The first way that we would use endoscopy is to treat hydrocephalus, which is the fluid circulation problem associated with a brain tumor endoscopically. So this image, this drawing that you see on the left, is an image of the brain. The ventricles, these fluid spaces are enlarged. Fluid is normally produced here in the lateral ventricle and then travels into the third ventricle, and then it wants to travel via a channel here called the cerebral aqueduct into the fourth ventricle. But in this illustration, you can see that there's a tumor which is blocking that cerebral aqueduct, so the fluid can't pass, and these ventricles enlarge in a compensatory manner. And that's what gives the child the symptoms of headaches, vomiting, etc. So what I can do with an endoscope is to drive an endoscope into the brain and make a hole in this membrane, which is called the floor of the third ventricle, and we can make a hole so that the fluid passes in front of the brainstem because the tumor is blocking it from passing behind, and it's actually much safer to make this passage than it is to try to remove this tumor or to try to create a new passage in the spot where the tumor is. So here are a few intraoperative images, And I'll show you some videos which include endoscopic third ventriculostomy later. So this is the view that we get in the lateral ventricle, which is this spot right here on the diagram. And what we're looking at, this opening is the foramen Monro, which is the opening through which we pass from the lateral ventricle, shown here, into the third ventricle. These are veins which we need to preserve. This is the septal vein towards the midline. This is called the thalamostriate vein. And this is beautiful pink choroid plexus. This is the substance in the brain which produces the fluid. So we travel into the third ventricle. So now on our diagram, we're here. And this is the view that I get. These arrows are called the mammillary bodies. And this is the infundibular recess under which the pituitary gland sits. And this is the clear membrane on the floor of the third ventricle where we're going to make our hole. That's called the tuber cinerarium. And once we make our hole, we're going to be in this space right here in front of the brainstem. We have to be careful because there's an artery there called the basilar artery, which if we injure could be catastrophic, but we're very careful not to do so. And it's quite easy to avoid doing so. So here you can see a balloon that we use to open up that passage. And this is, on the right, the hole that you see once the third ventriculostomy has been complete. Here's an example of a child who benefited from this procedure. So this is a 9-year-old boy who presented with headache, nausea, and vomiting. He's got massively enlarged ventricles of the brain, as you can see. This signal outside the ventricles is called transependymal absorption of CSF. What that means is that the pressure is so high in the brain that the fluid is being forced out of the ventricles into the brain tissue itself. And the reason he has this problem is because of this very benign appearing tumor that's located in the back of what's called the midbrain, which is the highest part of the brainstem. This type of tumor is called a tectal glioma. It's a benign tumor. We can diagnose it based on imaging alone. It does not need to be biopsied, and all we need to do is treat the hydrocephalus. So at the bottom is an MRI scan soon after an endoscopic third ventriculostomy. The ventricles are still large, but that transependymal absorption of fluid that you see here is now gone. And you can see this sort of black jet. I don't know if you can make it out on your screen, but where the color is transitioning from brighter to darker is fluid being forced with every heartbeat through that floor of the third ventricle, which we created. Most importantly, so this was performed in 2005 on a patient of mine. Most importantly, the child's headache, nausea, and vomiting completely went away. And his parents even noticed that his concentration improved. He's a straight A student. He's required no additional treatments for this tumor. And we've been following him now for 7 years. Well, just about 7 years exactly. So this next patient is a really nice example of avoiding in what most centers would be a large craniotomy, but in our center we would perform just a minimally invasive endoscopic procedure. So this is the MRI scan on the right of a 15-year-old girl who presented with visual field loss. She wasn't seeing well in the periphery. She also had increased thirst, suggestive of a problem called diabetes insipidus, when your hormone balance for fluid is not working properly, so you're always drinking a lot and urinating a lot. This led to an MRI scan of the brain which showed this lesion in the suprasellar area. And in a child of this age who presented with these symptoms, I knew that the most likely diagnosis was going to be what's called a germinoma, which is a tumor which should not be treated by surgery and has an excellent response rate to either radiation or chemotherapy with an over 90% cure rate. So we performed an endoscopic biopsy, which means we made a very small incision right here at the top of the head, brought an endoscope into the ventricle, the lateral ventricle into the third ventricle, and we're looking at this tumor. This surgery literally took about 15 minutes, and I'll show you a video of the most important portions of the procedure. It takes just a minute for the video to come up, and here it is. So we're in the lateral ventricle. This is the foramen Monro, and we introduce our biopsy forceps. We see the tumor filling that third ventricle, and we take our biopsy forceps. We take a few small bites of tumor. There's a little bit of bleeding, which is easily controlled with irrigation. taking some more bites of tumor. And that's basically it. And including the incision and the closure and everything else, this tumor took somewhere between 15 and 30 minutes. The pathology was indeed germinoma, as we predicted. And the patient was treated with radiation therapy with a complete response, and she's cured of her disease. Her visual field's normalized, and she's on hormone replacement therapy, because once the hormone processes are disrupted, they often don't reverse themselves even with therapy. So basically, she has a normal life but has to take a few pills each day. Here's an example of a patient who presented with a pineal region tumor. I mentioned those briefly before. He presented with headaches and vomiting because this tumor was blocking the fluid passageways of the brain, blocking the cerebral aqueduct, as I mentioned. And we have two problems in this child. One is we have a tumor and we don't know what it is. And there are certain tumors that would need a surgical resection. There are others that would need radiation therapy. There are others that would need chemotherapy or a combination thereof. The second problem is that he's got hydrocephalus. The ventricles, the fluid spaces of the brain, are enlarged. So in one single procedure with a small incision on the top of the head, we can perform an endoscopic tumor biopsy and simultaneously perform a third ventriculostomy. So we did so. We introduced the endoscope. We make our hole. And I'll show you a video of the third ventriculostomies a little bit later in another patient. I just don't want to duplicate myself. We made our hole in the floor of the third ventricle. We biopsied this tumor. It was the exact same diagnosis, germinoma, as in the last case. So this is not a surgical disease. The child received radiation therapy and chemotherapy and had a complete response and never required a shunt or any other additional treatment for the hydrocephalus. So in many centers around the country, this child might actually get a shunt. And those of you who have children with shunts know that shunts can have a lot of complications. They are very effective in treating problems with fluid circulation, but they can block, they can break, they can have a number of problems. So anytime as a pediatric neurosurgeon I can avoid a shunt, I do so. And this is a good example of that. So this next case is one that I'm particularly proud of. A very interesting case, one that was actually so interesting that we published it in the medical literature because it was a very, very unusual presentation. And the things that were unusual was the child had very profound imaging studies of the brain. I mean, if you look here, the entire brainstem is filled with tumor, much of the cerebellum, etc. And this is much higher up in the lateral ventricle, and you see all these nodules of tumor, which was studying the lateral ventricles. And we had no idea what this was. The neuroradiologist had no idea what this was. But interestingly, this child was only minimally affected by this tumor. She had a slight weakness of her seventh cranial nerve, of the nerve which controls facial movement. So she had an asymmetric smile, and that was basically it. Despite the fact that her ventricles were enlarged, she was not symptomatic at all from a blockage of fluid circulation. And what that indicates to a pediatric neurosurgeon is that she probably had this problem going on for years and years, which suggests that it was likely a benign process despite the profound imaging studies. So I wanted to both make a diagnosis and treat the hydrocephalus. And so we did that endoscopically. And what you'll see in this next slide, it takes a little bit of time for these large video files to come up, is that we did an endoscopic biopsy and a third ventriculostomy simultaneously to make a diagnosis. So here's the video. This is the septum pellucidum on the right, which was completely blown out. That's the membrane between the two ventricles. We enter into the third ventricle, and you see all these nodules. These nodules were actually more striking when we were actually there with the endoscope than they were on the MRI scan. And now we're doing the third ventriculostomy. We take a blunt instrument. We make a hole in the floor of the third ventricle. And you see us widening that. And every nodule here is tumor. You shouldn't see any of these nodules in front of you. So here we are widening that hole. Now we're going in with a balloon. And once I make a hole, I want a big hole that you can drive a truck through, because you don't want that hole to scar over and close, because then the patient will have a problem with fluid circulation. So now we drive into what we call the interpeduncular cistern. We see the basilar artery. You saw a glimpse of the basilar artery right there. And you can see that nice pulsation with every heartbeat as fluid is forced through that hole. And now we can take biopsies of this tumor. So we took a number of biopsy specimens and we sent it to the pathologist. And here's the view at the end of the surgery. Here's the choroid plexus, the foramen Monroe. We can't cure this child with surgery, so we don't do more than a biopsy. But we want to make a diagnosis and treat the tumor and treat the hydrocephalus. So the pathology was a neurocytoma, which is a benign tumor. And these were some of the pathology slides. And basically, we observed this child without any additional treatment for about 4.5 years. This patient is completely stable. Her MRI scans have not changed. She's a college student and doing beautifully with no additional treatment. Here's another example of also a rather unusual case. And this is another example of treating a different type of problem with fluid circulation in the brain with endoscopy, and also making a biopsy to try to determine what type of tumor. This was a 4-year-old boy who presented with headaches and vomiting, and he's got all this tumor filling the lateral ventricle, filling the third ventricle, partially involving the suprasellar space, involving the septum pellucidum, which is that membrane between the two lateral ventricles. And what you can see is that the ventricles on the left side of the brain, left and right, are backwards on MRI scans. So the left ventricles are much larger than the right ventricles. And especially on the left side, you see all this transependymal absorption of CSF, indicating high pressure. So I had 2 goals with this initial surgery. One was I wanted to make a biopsy because, once again, this was an unusual appearing tumor. I had no idea what this was, so I wanted to know what it was so we can know how to treat it appropriately. The second thing I wanted to do was to make a communication between the 2 lateral ventricles so that the blockage of this foramen Monroe on this side, where the fluid goes from the lateral ventricle to the third ventricle, is less important because fluid could flow out the more normal side. So the next video, which will also come up in just a few minutes, I apologize for the videos being slow to come up, will show exactly that procedure. So here's the video. Here's the septum pellucidum, and that's the membrane which separates the 2 lateral ventricles. So we go where it's very thin and clear so we know what's on the other side. We make a hole, and we're widening that hole with this embolectomy balloon. And now we're driving the endoscope into the other side. So we've done a nice communication. And now we're biopsying the tumor, which is blocking that foramen Monroe, where the fluid from the lateral ventricles normally goes into the third ventricle. So we take a few biopsies. There's a tiny amount of bleeding, which goes away with a little bit of irrigation. And that's essentially the surgery. Again, this is probably a 15 to 30 minute procedure from skin to skin with a very small incision. Here's the view at the end. So there are some tumors, as I mentioned, where our goal is simply to biopsy it, to make a diagnosis and figure out what to do next. And there are other tumors, and this is something that is increasingly going to become possible as the instrumentation becomes better. Right now we're a little limited by the instrumentation, but year after year it gets better and better, and there are more tumors that we can actually remove completely with a minimally invasive approach. So here's one example of an 8-year-old boy who presented with headaches, and he was found to have this small tumor, which was in the third ventricle, and the reason he was having headaches was because it was blocking the fluid circulation. And so we went in with our endoscope, and this is the view after surgery, and we were able to completely remove this small tumor, and we did a third ventriculostomy. While we were there, you can see the ventricles, the fluid spaces, are much smaller. Here's before surgery and after surgery. The tumor has been completely removed. This is a benign tumor called a choroid plexus papilloma, which requires no additional treatment and should be cured. So we will follow this child with serial imaging studies, and to date this child has not recurred. So I'm a pediatric neurosurgeon, so I only operate on children, but the only exception to that is occasionally some of my adult neurosurgery colleagues will ask me to operate on a patient who has a problem which can be treated endoscopically or another pediatric disease. And that's just because we do a lot of endoscopy, both for tumors, for hydrocephalus, for other conditions. And so we have that expertise. So this was an example when I was back in Miami on the faculty at the University of Miami, where one of my adult neurosurgery colleagues asked me to take care of this 36-year-old man who presented with 18 months of daily headaches. And the reason he has headaches is because he has this very, very large lesion filling the third ventricle, which is likely what we call a colloid cyst, which is a benign entity which can be cured with surgery. So what most neurosurgeons in this country would do is they would do a big craniotomy. They would separate the two hemispheres of the brain. They would go through this corpus callosum, which is a band of brain tissue which allows communication between the two sides, and have access to this tumor and remove it under an operating microscope. That would be about a 6-hour procedure with a large incision and a large scar, and the patient would be in the hospital for about a week. What we did was a small incision right here, going through a silent area of the brain into the ventricle and attacking this endoscopically. So here's a CT scan 2 days after surgery. The lesion has been completely removed. The fluid spaces, the ventricles are smaller, and this patient was discharged home 2 days after surgery with no headaches or any other symptoms. So in terms of future directions, I'm often asked by patients, which direction do I think this field is going in? What are going to be the treatments that are performed in the future? One is, I think you're going to see more and more neuroendoscopy. As the instrumentation improves, we're going to have the ability to resect more and more tumors with very small incisions, with minimally invasive approaches, with shorter hospital stays, and with fewer complications, hopefully. I think there is a scientific explosion regarding molecular studies. There are going to be new tumor markers to make a diagnosis. There are going to be individual tumor-specific expression profiles which predict response to therapies. So your child, when they have a brain tumor, will have a biopsy perhaps, or a resection of a tumor, and then that tumor will be studied. And rather than a generic approach to all patients, you will have an individualized approach where you know that your child's tumor is going to respond to a specific type of therapy because it's been tested against that therapy already in the laboratory. And of course, there are many new therapeutic approaches on the horizons. Immunotoxins, anti-angiogenesis agents which attack blood vessels. There are a lot of blood vessels in some of the more vascular tumors. Cell-directed therapy, radiation sensitizers which make the radiation therapy more effective, etc., etc. So one area which is particularly exciting to me, and this has been a passion of mine for the past 7 years, one of the problems with treating brain tumors in children that are malignant is they need chemotherapy. And chemotherapy is problematic in the brain because the brain has a great ability to protect itself by something called the blood-brain barrier, which is a barrier which prevents chemicals and infection and other things from entering the brain. So the problem is you have to give chemotherapy in such high doses that it's very toxic to the children. And I've seen children require liver transplants because of damage to their liver from chemotherapy. Now, we don't need to treat the liver because these tumors don't even go to the liver. It's just that there's such high levels of these chemotherapeutic agents in the bloodstream which makes children sick. And I think that 50 years from now, when we look back on the current chemotherapy treatments of brain tumors, truthfully, we're going to look back on it as a barbaric era, and I hope we do because there are much better ways of treating these patients. So what I've been doing in animals, first in pigs and then in non-human primates over the past 7 years, was looking at local delivery of agents directly into the part of the brain that's affected by the tumor, and I'm specifically focused on the fourth ventricle of the brain. So this is the area of the brain between the cerebellum and the brainstem where the most common malignant brain tumor in children, medulloblastoma, occurs, and other tumors such as ependymoma, atypical teratoid rhabdoid tumor, and other tumors can occur, and these tend to be aggressive tumors. So here's a view in a primate, in a non-human primate. In an experiment, we've exposed the cerebellum, and this is the brainstem, and the spinal cord would be below. This is the dura, which is being tented open. Here's an artist's rendition on the right. This is an expanded view. And now we've inserted a catheter, which you can see directly into the fourth ventricle of the brain under direct vision. We're not going through any brain tissue. And The catheter is sitting right where we want, and we can deliver chemotherapeutic agents. Here's an MRI scan in one of these primates showing the catheter sitting right in the fourth ventricle where we want, and after receiving chemotherapy, the brainstem is completely normal with no signal changes or other damage. The cerebellum is also completely normal. There were no other signal changes anywhere in the brain. So basically, and the animal's neurological examination was normal as well. So we have not hurt this animal by giving chemotherapy exactly in this spot. And the exciting thing is that this has led to a clinical trial which we're going to be performing at Children's Memorial Hermann and the University of Texas MD Anderson Cancer Center. So this is a trial that I'm very proud of because it comes directly from our translational research, and hopefully it's going to offer a new and more promising treatment option to patients. And we're in the final stages of IRB, Institutional Review Board approval for this trial, and we should be underway shortly. So thank you very, very much for your attention. I'm very grateful, and now I'm going to begin to answer some questions. So the first question, which was asked to me, is what if you have a pilocytic astrocytoma, but it's partially attached to the brainstem? That's a great question. So what we want to do is we want to remove all of the portion of the tumor which is called exophytic. Exophytic is the portion of the tumor that is not within the brainstem. You want to remove the portion that fills the fourth ventricle of the brain, and you can leave a small amount of a pilocytic astrocytoma attached to the brainstem. This is a benign tumor, and you can follow it with serial imaging studies, and very frequently that tumor can stay stable year after year after year. If it enlarges years later, you can either go back and do surgery, or you can treat that child with radiation therapy. So moving on to the next question. So the next question is, what is the recovery time in the hospital after brain surgery and after minimally invasive procedures as well? So for a traditional brain tumor operation, for a craniotomy where we do a large skin incision, remove a large piece of bone, typically a child will be in the intensive care unit for 1 to 2 days after surgery, and then they'll go to the floor. And the criteria for discharge are they have to be able to walk around on their own, they have to be eating well, and they have to not require IV pain medicine. And on average, that ranges between 5 and 7 days of total hospitalization. For the more minimally invasive endoscopic procedures, some of the patients need to be observed to make sure they don't have a problem that continues with fluid circulation in the brain or other issues, but many of those patients can be discharged much sooner. So the earliest I've ever discharged a patient after one of these minimally invasive procedures is the next day, 24 hours after surgery. More commonly, we keep them in the hospital for 48 to 72 hours. So moving on to the next question. So the next question that's asked is, what are the criteria to be accepted in our clinical trial? So in our initial clinical trial, the patients who are eligible are patients between the ages of 0 and 22 years of age who have recurrent medulloblastomas, ependymomas, or atypical teratoid rhabdoid tumors, and there are a number of other more detailed eligibility criteria, but those are the patients that we're targeting for this initial trial. And I think I just answered the next question, which is, can you tell us what histologies will be allowed for the trial that you've just discussed? The next question that's asked is, are the symptoms for brain tumors and spinal tumors the same? Typically not. Brain tumors will typically present in children with signs of elevated pressure in the brain. Spinal tumors obviously will not do that. And they'll also present with symptoms that are associated with the exact region of the brain which is affected. In the spinal cord, the symptoms and signs will be associated with the area of the spinal cord that's affected, but also more commonly the symptoms in the spinal cord will be bilateral. They'll be on both sides. So a tumor in the spinal cord will often present with weakness of both arms and legs. For example, if it's in the cervical or neck region of the spinal cord, where it would be very unusual to have bilateral symptoms for a brain tumor patient. The next question that's asked is, has anyone ever administered chemotherapy in the fourth ventricle of the brain before? And the answer is no. And so we're going to be the first ones to do this. And this is based upon the work we've done in animals. I've done everything I can over the course of a number of years to prove that this is safe. After our initial pig experiments, which were published in a number of journals, many of my colleagues around the country told me that they felt that we had enough information and enough safety data to proceed in humans. But I felt that before I would ask permission from a parent to consent their precious 3-year-old child in a clinical trial for something that has never been done before, we ought to get even more safety data. So we then worked in non-human primates because their neurological examination is so much closer to that of humans. And once we demonstrated safety data in primates, we now feel that we're ready for human clinical trial. The next question is there a genetic link to brain tumors? And a follow-up question to that is, do siblings have an increased risk of developing brain tumors or other types of cancer? So the answer to that question is that there are probably genetic changes that are associated with tumors, but the overwhelming majority of pediatric brain tumors are not attributed to a specific genetic abnormality. And as far as siblings and other family members being affected, in general, unless you have a specific syndrome which is familial, such as neurofibromatosis or Gorlin syndrome or a variety of other syndromes which are present only in a small minority of patients with brain tumors, the risk in siblings and the risk in parents and children also is similar to that of the general population. So we don't recommend screening studies in children. And let's see if there are any other questions. There was a question, what is ultrasonic aspiration? I apologize, I wasn't answering questions in the middle of the talk. I waited till the end. And is this an option to help in this situation? Ultrasonic aspiration, also known as cavitron ultrasonic aspiration, or CUSA, is one of the many tools that we have to remove a brain tumor. And basically, under an operating microscope, and there are even smaller cavitrons that can be used through an endoscope these days, you can basically insert a probe, and that probe uses ultrasound to break up tumor. And there's also a suction device attached to the cavitron or CUSA machine, which once it's broken up, the tumor is broken up into little pieces by the ultrasound, it suctions out some of that tumor. And you can even collect that specimen through the tubing and send that specimen to the pathologist as well. And I think that is the final question. So I want to thank you once again for your attention and for participating in this webinar. And that's the end.